The next paper is the effects of timing of repair on mortality following thoracic endovascular aortic repair for blunt thoracic aortic injury, presented by Charles Marquardt with senior author Dr. Smeds from SLU.
I'm Charles Marquardt. I'm one of the integrated vascular surgery residents at St. Louis University Hospital, and I'll be discussing the effects of timing of repair on mortality following thoracic endovascular aortic repair for blunt thoracic aortic injury. I have no disclosures relevant to this talk. Blunt thoracic aortic injury is associated with a high mortality rate that is a common cause of death in the trauma patient. The Society of Vascular Surgery grading system classifies these injuries into 4 grades. Grade 1, an intimal tear, can be managed medically and surveilled. And grade 4, frank rupture, requires emergent repair, usually in the form of TEVAR. The optimal timing of repair for grade 2 and 3, however, remains debated. SVS clinical practice guidelines covering BTAI were last released in 2011, and at that time, urgent repair was suggested within 24 hours of injury. Studies since then looking into timing of TEVAR for BTAI have been limited to unknown grade of injury, single-center studies, small sample size, or designed to compare medical and surgical management and not look specifically at endovascular repair. The aim of this study is to answer if the timing of repair for grade 3 and 2 blunt thoracic aortic injury affects mortality. The Aortic Trauma Foundation database is a collaboration of the ATF and the American Association for the Surgery of Trauma and contains over 1,000 subjects from 44 centers across North America and Europe. This international prospective multi-center registry aims to collect data on the diagnosis, management, surveillance, and outcomes after BTAI. Using this database, we identified grade 3 and grade 2 blunt thoracic aortic injuries between 2015 and 2022 to examine outcomes based on time to TEVAR. 2 groups were analyzed based off time to intervention, with early repair defined as that which occurred within 24 hours, and late repair consisting of repairs occurring after 24 hours. Physics exact t-tests and chi-square analysis was performed for univariate analysis, followed by a multivariate regression analysis. A p-value of less than 0.05 was considered statistically significant. Over this time period, 928 patients were entered into the database. 460 were managed medically, 468 were managed surgically, and 459 were managed via an endovascular approach. Of these, 383 were grade 2 and 3 treated with TEVAR. After removal of patients with incomplete data sets, 222 patients were analyzed. Of those grade 2 and 3 injuries treated with TEVAR, 179, or 81%, were repaired within 24 hours, and the remainder repaired after greater than 24 hours. The average time to repair in the early group was 5.7 hours, as compared to 109.3 hours in the late group. Comparing the baseline demographics between the early and late repair groups, patients with a widened mediastinum and patients with a shorter distance between the site of injury and left subclavian artery were more likely to undergo early repair. The remainder of the variables were similar, including injury severity score, mean arterial pressure on arrival, GCS, and lactic acid. When comparing patients who survived to those who did not, those were several differences. The patients who died were more likely to have baseline coronary artery and peripheral artery disease, a history of angina, and prior cardiac revascularization. Looking at hemodynamic variables obtained on arrival after injury, systolic blood pressure and mean arterial pressures were higher in those that survived. The GCS was higher, and the injury severity score was lower in survivors. Looking at lab values, those that died had higher lactate, lower hemoglobin, and lower pH values. The overall 30-day mortality of the cohort was noted to be 6%, or 14 patients, with aortic-related mortality occurring in only 2 patients. The overall mortality for patients in the BTAI database was 12%. On multivariate analysis of pertinent variables, hemoglobin, injury severity score, and grade 3 blunt thoracic aortic injury was shown to be significantly associated with mortality. The timing of repair of the injury was not associated with survival. The variables associated with mortality in patients with blunt thoracic aortic injury were as expected and correlated with overall more serious trauma and coexisting injuries. The overall aortic-related mortality was low at just 2 patients, although given we were looking only at grade 2 and 3 injuries, all of which underwent TEVAR, this is not surprising. Importantly, in our analysis, the timing of TEVAR following injury for grade 2 and 3 patients did not affect mortality in relatively similar groups in regards to preoperative variables. Limitations of this study included the database nature of the collected data. This database, however, is multi-institutional, highly detailed, and contains many variables specific to blunt thoracic aortic injury which are not included in other registries. Additionally, a selection bias certainly exists as to which patients undergo TEVAR early or late, depending on the severity of other injuries and morphology of the aortic injury itself. Aortic injuries are on a spectrum within the grading system, and a severe grade 3 injury may not be appropriate for late repair. In conclusion, in select patients, delay of the performance of EVAR for BTAI may be possible. Our data may allow greater latitude in surgeon discretion as to when repair is performed for these injuries based on individual patient presentation. I'll be happy to take any questions.
Dr. Rajani. Hey, Ravi Rajani, Grady Memorial, Emory. Great presentation. Thanks for using the ATF data to try to drive some points home. I think, important to remember that the SVS guidelines are pretty far out of date, and they're in the process of being rewritten. There's several of us in this room who are involved with that, and part of it is because the grading scheme is really outdated. I know Alina was here earlier, but she may have left. I think most major centers have stopped treating SVS grade 2s, and we try to rely on things like the Harborview classification to help guide clinical data. So do you remember what percentage of your patients were 2 versus 3? I noticed you put them together, but I think if you took a straw poll, we'd all still fix 3s, but a lot of people would say we're really not fixing 2s very much, so I think you have to be careful about putting them together. I would also encourage you, we come from this place over the last 10 years and we approach it as it's okay to wait, but we really need to change that to it's better to wait. And obviously there's a lot of selection bias in the early versus late repair here, but what really drives that decision to wait, I think, is still spinal cord ischemia and still stabilization of other injuries, getting someone to the point that they can have an endograft implanted safely without risk of their spinal cord being injured. And if you look at the chronologic data around blunt thoracic aortic injury, we've seen improvements in SCI rates over the last 30 years because of the strategy. But I noticed you didn't have much around spinal cord ischemia, and I think if you're going to talk about early versus late, think about using spinal cord ischemia as a better outcome measure than mortality, because as you saw, honestly, almost no one dies of aortic-related mortality at this point in the modern treatment of this disease. Great job.
Yeah, absolutely. The mortality was low, as you said. I don't have the numbers off the top of my head, but most of these patients in the grade 2 versus grade 3 were grade 2. There was certainly a number of grade 3, but we did lump them together. If we separate those out, I'm sure we'll find something similar to what you were saying. With spinal cord ischemia, those are similar across all the groups. I didn't present the data here, but we'll look into it for the manuscript. And there is definitely a balance there between repairing early and repairing late when you have patients who are significantly ill. With trauma patients, it's much more of a focal problem, so I think coverage of the aorta and that kind of thing is going to be less of an impact as when you're covering down to the celiac, but it's definitely something to consider.
Yep, totally.
Nice work, nice paper. It was interesting to note one of the variables that portended mortality was cardiac revascularization. So were you able to tease out how many of these patients had a Lima graft to LAD and how many were covered for the submergent setting? The LSA.
We didn't look at that specifically for this paper, but the database, as I said, is incredibly detailed, and that information might actually be available. So that would be something to look into when we do our further analysis and produce the manuscript. That was very interesting.
Nathan Lane from Pittsburgh. I enjoyed the talk very much, and we have also had the same experience with our trauma patients that have blunt thoracic aortic injury. I am very curious as to whether or not it's even possible for you to tease out a little bit more why there was so much discrepancy between early and late, like why people repaired them late versus early, because generally in ours, it's even though we've started to lengthen the time between diagnosis and repair, a lot of times, like Dr. Rajani said, we're still waiting for things, like people to have their bones fixed and people to be stabilized in the ICU. And I know that a higher ISS in your study really does associate with worsened mortality. But if there is a way to really tease out why some people waited and some people don't, I think that's a really important selection, because probably a lot of those people that got done early might have been part of the institutional protocol, but probably they just didn't have other injuries and could be done sooner. What do you think? Can you guys see that in your data?
Absolutely. Well, the only difference between the early and late groups was the widened mediastinum and the left subclavian artery distance. I think widened mediastinum is very obviously an indication the morphology of the injury was probably worse. And like I said, the grading system doesn't take into account a spectrum within the grading system. So
right.
I'm sure there's differences.
Yeah, but you don't have any physician decision-making variables in there or anything like that.
There aren't. I mean, it's a database study, so there aren't physician decision, but there are actually quite a lot of details in there that maybe will come out in the manuscript.
Just going to echo what Dr. Rajani said. We used our grading system every time, right? And we understand that you can talk about semi-elective. You can have earlier repairs. It's not like you can't do it. If everything's cleared and the patient's clear to have an early repair, you can do it. You usually pick something convenient. Like if somebody comes in at 1 o'clock and they have to get cleared 1 o'clock in the morning and they have to have their head cleared, they may have a bleed, they may have a pelvic fracture and all these other things. Early and late repair can be up to the surgeon's discretion. So I think sometimes we get, we say it's semi-elective, we should wait. We do wait. But once they're clear, if it's an opportune time to fix it, then we fix it. And so I think your point is that it's going to be hard to tease that out because it's going to be surgeon's preference on a lot of that.
Absolutely, and there's a balance between the recommendations that, again, the last ones we have are from 2011, saying that you should try and do it within 24 hours, but you can reasonably push that if you have patients with brain bleeds and pelvic bleeds and all those things that you're trying to avoid heparinizing them for the procedure. I think it's an important piece of data to move forward with.
All right. Thank you very much.